morning. Welcome to the ETSU Department of Psychiatry Grand Rounds. Today we welcome Dr. Jerome Cook. Dr. Cook is the clinical psychologist with the James H. Quillen VA Center Substance Use Disorder Program and has been there since 1992. Clinical assistant professor in the Department of Psychiatry and Behavioral Sciences here at Quillen. Dr. Cook received his degrees from Davidson College and Vanderbilt University. He's been involved with the prevention and management of disruptive behavior program since coming to Mountain Home, and is co-chair with Dr. Hayel in the Disruptive Behavior Committee. Today, the title of his presentation is Violence in the Healthcare Workplace. Thank you for coming, Dr. Cook.
Thank you. Is the microphone working okay for everybody? All right. Good. I appreciate everybody coming here on April Fool's Day. I don't know if there's anybody from around this area, people that grew up in this area might remember there was a political person in Irwin that decided, I think it was an emergency management coordinator a few years back, that decided to hold a drill without informing anybody that he was going to hold an emergency drill involving violent behavior at the meeting. So I'm not going to do that, even though it is April Fool's Day, but so I appreciate you coming. That's the standard disclosure. I don't have any financial interests or arrangements, anything. Okay, good. And yeah, there we go. Sure this is working. Okay, so this is the standard OSHA definition of workplace violence. It's pretty straightforward. It's notable that it includes both harassment and intimidation, so not just threats of physical violence. I think that's an issue. Oftentimes that comes up. There's a lot more contact these days that is not just face-to-face, but involves not telephone, but also now email and web-based communications. And so that's already been noted and has occurred to some extent in our facility regarding different types of ways that harassment and intimidation can be communicated. And it's defined as threatening disruptive behavior that occurs at the website. So the fact that OSHA, the Occupational Safety and Health Administration, provides that definition is also important in that they're responsible, as we'll see, for regulating the efforts to reduce the risk of workplace violence. So there's several recent news items, I say recent in the past year or so, that have heightened concern about violence in the healthcare workplace. I like to get the scary. If the data is correct, then it's likely that many of you have experienced uncomfortable or perhaps threatening experiences in the workplace already. So I get the scary stuff out of the way. And so the first example here is an extreme example of violence related to an incident that potentially involved grief, depression, and financial stress, and attributions of responsibility from a family member. This is where a surgeon was slain at the Brigham and Women's Hospital in Boston. So a family member lost her life, somebody's mother, and the son attacked and killed the surgeon that he felt was responsible. Second item that everybody saw in the news in the past year, domestic terrorism in a healthcare setting, the Colorado Springs shootout at the Planned Parenthood Center. Third item is pretty sensitive to me, being a psychologist at a VA medical center. This was where a VA clinic clerk former clerk, was a gunman who killed a psychologist. That people may remember that incident. I think we were just talking, I think that happened in Texas and involved somebody that was turned down or had a bad outcome of his compensation and pension hearing. So, let's see. And the fourth item involves Brookdale Hospital, which is a 790-bed hospital in New York that was fined $78,000 for 40 instances of violence that occurred between February and April of 2014. So they found that OSHA in the past year, I believe 75 of 114 workplace violence inspections were in healthcare, and 31 of those resulted in a hazard alert letter, and 15 of the 75 that involved healthcare led to citations and fines. So it's a concern for OSHA that they stay on top of. So it's a growing problem for healthcare workers. I've got some additional statistics, I thought, because while the first three items reflect the more sensational and rare instance of extreme violence, the last item summarizes the much larger concern of pervasive violence in healthcare. And it mentions that a survey that was done just in 2014 of 762 nurses at an urban hospital found that 76 reported violence in the past year. That's included 54% reporting verbal abuse and 30% reporting physical abuse by patients. Some of the particularly, I don't have a slide for this, but one of the more interesting statistics when you really dig down into the data, and you can get these data through the Bureau of Labor Statistics, but some professions are much more dangerous than others. Anybody want to guess as to which is the most dangerous profession in healthcare by a country mile? Psychiatry. That's good. That's the right area. If we nail down what job title? Close. Psychiatric aides. So psychiatric aides were more likely, in 2013, they experienced the highest rate of anybody in any industry, 590 injuries per 10,000 full-time employees. And that's 10 times higher than the next group, which is nursing assistants, who experience 55 injuries per 10,000 full-time employees. Registered nurses, 14 injuries resulting in this is serious injuries resulting in days away from work is how they define that. And that's compared with a rate of 4.2 in all of private industry. So psychiatric aides, 590. Nurses, nursing assistants, 55. Private industry, 4.2. Pretty big difference. So the good news, though, is that we're much less likely to die from occupational injuries in the workplace. If you want to see if this pointer works here. This doesn't have actually the most dangerous occupation because it falls in one of this. Anybody want to guess what the most dangerous occupation is, just for death in the workplace? Construction. Now it's more specific, huh? Anybody else want to take I thought somebody else wanted to take a guess. It's not on here. What's that? Stunt people. That's a good one. Yeah, that's a good guess, and that's probably for fatal occupation. I think this may not include more specifically homicide in the workplace. The most dangerous one is taxi drivers, much more so than police. They're alone, dangerous areas with money, typically. Maybe less so now these days that people have the cars and everything. That has been, even taxi drivers these days, a lot of times they're dealing with money. So you can see, here on the left, fatal work injuries, so construction is the most dangerous of these classifications of industries, and this is from the Bureau of Labor Statistics. And so if we look down here, what are we talking about? Healthcare, educational and health services. There we go, 84. So percentage-wise, the most dangerous, fishing, but industries, then logging, that type of thing. So I don't know if that includes mining is up there. But anyway, percentage-wise, that's the most dangerous. And again, educational and health services way down there. So that's good news. We're unlikely to die at our jobs. That's something, right? Yeah. I don't think they include military in the BLS statistics. So that's mostly police. And you can see here, in terms of workplace homicides, retail trades. So again, motel employees, convenience store operators, liquor store operators, kind of places you'd think might be prone to robberies and violence, have the highest rates of death by homicide from shooting. This is pretty specific. This was in 2010. Again, this is BLS statistics. And there's a total of 405 deaths by shooting in that year. In educational and health, there were, I think that's 4%. So it's like, that's, what would that be? So anyway, I think that would be 4. So anyway, going on. Okay, so now I've showed you the good news. We're unlikely to die. The bad news, I kind of hinted at that already. If we do die, is a quarter of us are going to die from violence in the workplace. So other causes of healthcare fatalities, typically transportation, and so that's where a lot of accidents happen and deaths happen on the road. So, and then falls, trips, and exposures down here. So. Again, some more good news, or well, this is actually, no, this is the bad news, I'm sorry. The bad news is, again, non-fatal injuries in the workplace. I mentioned that the really specific, when you nail down, the psychiatric aides, nursing assistants, people that have hands-on contact, much more likely to have non-fatal injuries. And so they're up there in the top 4 in terms of healthcare support. This is the total average for private industry, state and local government, and healthcare practitioners. So practitioners, I guess we're talking doctors and other technical practitioners, less likely. But there's still a lot of concern in the workplace about incidents of violence, and that's something that I work myself. One of my position is with the substance use disorder program, so I'm working with a high-risk population, as we'll see, in terms of diagnoses, and have been verbally assaulted but never physically attacked. So I feel fortunate in that, and that's over 25 years. Well, I want to move on. We talked about incidents. I want to go ahead and talk about prediction for a little bit now, and then we'll talk about prevention and management strategies and what we do in the VA to try to manage workplace violence. Prediction is pretty tough, as you can imagine. There's most well-known studies of prediction of violent behavior stem from Robert Hare's work in psychopathy checklist. Anybody read the psychopathy test or by John Ronson? Maybe saw that. Yeah, it was. I see some, not particularly not a scholarly book, but it was interesting. But he's working at the University of British Columbia, and he's been working in that since the 1970s. A lot of that work that was done is mostly with forensic populations, violent offenders, and a lot of that is some of that's done with psychiatric patients as well. But you really got to look at the populations that they're looking at, and even with those populations that are very high risk, it's oftentimes difficult to predict future violence. As violence is a low base rate behavior, obviously it's relatively rare compared to nonviolent behavior. So because it's rare, even factors that are strongly associated with violence will be less likely than not to accurately predict violence. So typical example is men are much more likely to be violent than women, but obviously, fortunately, most men aren't violent. So that's a problem with making base rate assumptions. There was a meta-analytics study that was done of a couple of meta-analytic studies. I'll mention one, and then we'll go to another one one that was recently done was measured 73 samples, nearly 25,000 individuals, and noted that while risk assessments were highly accurate and negative predictive value in predicting those at low risk for violence, so the median was 91%, they were only low to moderate in terms, at median of 41% in terms of a positive predictive value in terms of accurately predicting future violence. So they suggest that to inform treatment and management decisions, the instruments that we're going to talk about here in a minute might be reasonable, or they perform moderately well, but they're not accurate enough to make critical sentencing or detention release decisions. At least they make that argument. Brazil does. They make the statement that, and make a pretty bold statement even, that the view that violent, sexual, or criminal risk can be predicted in most cases is not evidence-based. And I also mentioned actuarial versus structured clinical judgments. Actuarial is basically based on static factors such as age, gender, history of past violence, history of criminal activity, different, whether a male or female victim was involved, those types of factors. Whereas structured professional judgment models of prediction typically look at a wider range of variables, typically 20 to 30 variables that they'll look at. And that tends to increase the comprehensiveness over actuarial models. They can place more emphasis on dynamic variables rather than static variables, so things that can change, like attitudes, negative attitudes towards people or institutions, response to treatment, that type of thing. And so the structured clinical judgment might include also relative and a qualitative risk assessment. So typically, this person's at a low, moderate, or high risk of violence in the near future, as opposed to a numeric assessment. And also because they tap into a lot more variables, they tend to be more readily translatable to samples that are not exactly like the actuarial samples, which tend to be sample dependent in terms of their statistics. So there's another meta-analysis that was done in 2010. They looked at 9 violence risk assessment tools to see which one performed best. This one was a psychological bulletin article. They looked at 28 studies between 1999 and 2008. They found that meta-analysis of 9 tools were of moderate efficacy and were largely interchangeable, except for, interestingly, the psychopathy checklist, the original, was no greater than chance. And they found the others down there below pretty much interchangeable in their effectiveness. So of those that are up there, actually use the HCR. It stands for history, clinical, and risk management factors. So there's 20 items that cover those 3 areas. The 4 that measure mostly static variables are more actuarial, or the Violence Risk Appraisal Guide, the General Statistical Information for Recidivism, the Risk Matrix 2000 for violence, and the Offender Group Reconviction Scale. Those tend to have been more static variables, were more likely to be in forensic settings. The Level of Service Inventory revised, the HCR 20, and the Violence Risk Scale were more dynamic and So as I mentioned, all those tools predict violence at a moderate level of efficacy except for the PCL, which is probably pretty good because anybody here familiar with that PCL? It's a very extensive test. And it takes an interview and review of data, so it takes some time. It was basically where Hare was trying to identify the personality trait of psychopathy rather than predicting violence is how it originated. But then they found that they thought that it had some usefulness in predicting violence. And they divided into two factors. The PCLR first factor is largely narcissistic manipulative behavior. It's what colloquially referred to as the initial psychopathy. And the second factor now is the more criminal, antisocial personalities. What you see more in the DSM now is more reflecting the actual criminal behavior. And those two factors, it seems that most of the ability to predict violence centered on the actual criminal behavior rather than the psychopathy personality traits. For most of these, the outcome measures were based on violent crime reconvictions in the community or aggression in institutions. All 9 did predict violence better than chance, moderate effect sizes. The violence base rates varied a lot. However, there was, in the 28 studies, somewhere between 4.8% over a 5-year follow-up to 100% in a 2-year follow-up of one sample. And only the offender group reconviction scale and the HCR20 were significantly better than the PCLR. So that's good because we tend to use the HCR20 as a guideline in our local disruptive behavior committee. And age and follow-up time were also significant moderators of the ability to predict violence. Yeah.
Were these norms on individuals with, say, serious mental illness, so say a person with psychosis, or was this more looking at people that would fall under antisocial or psychopathic personality?
Well, yeah, I'm just going to mention 3 of those 9 instruments because there are 28 studies and they're all normed on obviously different samples. So I'll go over these 3 and it mentions the normative sample. You can see here this first one, so the psychopathy checklist revised, right there at the bottom, the normative sample was almost 11,000 violent offenders. Okay, but they say and patients. And I'm tell you, I don't use the PCL. I haven't been trained in that. A lot of the HCR came from that, but I don't use that myself. It's a 20-item checklist of perceived personality factors, like I mentioned, and behaviors, assessed by interview and data review. Mentions the interpersonal factors, the glibness, grandiosity, and lines. So those are the kind of the psychopathy personality traits that they were hypothesizing. The lack of guilt and empathy. And the second factor is more involving this impulsive, irresponsible lifestyle, criminal behavior. So it produces a maximum score of 40, and the cutoff for the label of psychopathy is 30 in the United States. And sometimes they'll use a cutoff of 25 for research purposes, they mentioned. And let's see. It should also be noted that research has not been able to replicate a 2-factor model in female samples. So it tends to be been replicated with male samples, but it's not working as well with female samples. This is the Violence Risk Appraisal Guide. This is more of actuarial assessment. So they included the PCLR score, so it did include that. But aside from that, there are measures of where you score early maladjustment, personality disorder, young age, separation from a parent before 16, failure of prior release, nonviolent offenses, never married, diagnosis of schizophrenia, victim injury, alcohol abuse, and having no female victims. So if you have those statistics, you score higher. This is something that's kind of just, again, it's used in Tennessee with probation circumstances. So on to the next slide. So this normative sample, again, male violent offenders. The assessment was conducted prior to a trial in a psychiatric facility. It was scored from institutional records. The outcome was a 7-year follow-up, so that's a long time. 31% of those people reoffended, and so that's how they judged the prediction. The area under the curve, operating characteristics, they predicted 76% of the area, which is a moderate effect. And their problem with using the Violence Risk Appraisal Guide as a clinical tool is it's mostly based on static factors that don't change with time of treatment. So it's not something we use. It does claim to be the most accurate. Of course, they claim to be the most accurate empirically supported tool, and it is used pretty widely, but particularly in forensic populations. So something that we tend to use more as a guideline is HCR 20. They just come out in 2015 with a version 3. It includes guidelines for assessment. It claims to be the most commonly used tool. It's shown to be equivalent to other tools, and like I mentioned earlier, it's even better than the PCL in some meta-analyses. It uses a structured professional judgment approach. So what that is typically involves 20 or 30 risk factors that are chosen on a basis of thorough review of literature rather than results of a single small study or small number of samples like actuarial instruments. It tends to enhance comprehensiveness of coverage in terms of risk factors because you're looking across all risk factors. It tends to promote generalizability across settings and samples. It helps evaluators and decision makers identify risk factors that are present and relevant to the individual being evaluated, and produces relative risk levels, so just low, moderate, or high. So it avoids some of the pitfalls of actuarial approaches like sample dependence, exclusion of potentially important risk factors, instability of probability estimates across samples, and difficulty in applying group-based probability to individuals. So a structured professional judgment model tends to use more of a simple narrative approach and derives from the number and relevance of the risk factors. So it allows for some flexibility in that the person may only have, for example, a few risk factors, but they may be much more salient or much more personal to the situation where you're trying to predict risk, such as a violent person who's got a history of violence against a healthcare worker will be much more salient to us where we work, obviously, than a violent person who's got a history of maybe barroom fights or that type of thing. So these are the 20 items. First, these are the first 10 are historical factors, and they include a history of violence, and they get a little bit more detailed if you get the actual instrument in terms of they look at history of violence as a child, as an adolescent, as an adult. Other antisocial behavior, again, as a child, adolescent, and adult. Negative relationships in intimate and non-intimate settings. Employment, substance use, major mental disorder, so they break that down into psychotic disorders, major mood disorders, or other major mood disorders. The seventh factor is personality disorder, and they break that down into the antisocial versus other personality disorders. History of traumatic experiences, and that's broken down into victimization or trauma experiences versus adverse child rearing. Violent attitudes and treatment or supervision response. So the other 10 factors involve the clinical and risk management factors, so 5 of each. These include recent problems with poor insight into the disorder, and that includes, they break that down into both poor insight into mental disorder and their own violence risk and their need for treatment. The violent ideation or intent, symptoms of major mental disorder, again broken down into psychotic, major mood, and other major disorders. Instability, broken down into affective, behavioral, and cognitive instability. Treatment or supervision problems, broken down into compliance and responsiveness. The risk management factors include unstable future plans, unstable housing, problems with support, and that's and then also includes problems with supervision, compliance, and that break that down to compliance or responsiveness, and finally problems with stressor coping. Some of the OSHA's identified some of the risk factors as well, and you look at these, it's pretty much where most people in healthcare work: risk, inpatient acute psychiatry, geriatric long-term care, emergency departments, residential and day social services. So, and just locally, our own facility has almost as many reports of disruption in our medical wards as well as our psychiatric wards. Some of the diagnoses that increase risk, these are pretty obvious. I'm sure you're already aware of these, but substance intoxication or withdrawal. And that may be fortunate that when I'm working with people that are already through detox, they're oftentimes, hopefully, generally speaking, not going through intoxication or withdrawal unless they sneak something in. So that may explain why I've been fortunate. But your ER settings and detox settings are where a lot of disruption obviously is going to occur. Dementia and delirium, getting down to CLC and living centers, that what we refer to as our, the nursing home settings, but also you get a lot of delirium on acute medical units. Psychotic episodes, whether due to paranoid schizophrenia or mania, personality disorders, depression, and adjustment disorders too. So recent losses can increase risk. And the CDC has identified some of these risk factors, like I've mentioned with patients, the intoxication, history of violence, and psychosis, but also some risk factors in the setting. So transporting patients, uncomfortable waiting areas, long waits, working alone, access to weapons, lack of staff trained, unrestricted movement, and poor illumination and security problems. They mentioned, and also we mentioned in our own prevention and management of disruptive behavior, just being alert to precipitating factors. So those that I talked about were kind of the predisposing factors, those that increase the risk, but the precipitating factors are when you see signs of verbal anger, frustration, threatening gestures, signs of drug or alcohol abuse, obviously presence of a weapon. You want to diffuse the anger through obvious good customer service, and as I'll mention, you want to avoid threats, avoid ultimatums. You want to avoid, in our role play exercises that we do, emphasize talking underneath their volume rather than trying to go with more volume. So try to talk quieter to bring them down. They would generally, you'll be able to see if they can cooperate and calm down to level, and particularly reflections, good active listening skills. One of my other interests is motivational interviewing, and good, solid reflections of their experience verbally can help to alleviate even dealing with people that are angry and upset and at high risk. So we've got some different components of our local behavioral threat management program. This is a national program. Some of those components are the Disruptive Behavior Committee that started locally here in 2003. Got patient record flags. Our training program is prevention and management of disruptive behavior. We've got an online disruptive behavior reporting system now, and that feeds into an annual workplace behavioral risk assessment. So in 1997, our Undersecretary for Health produced a letter mentioning that OSHA requires violent behavior prevention program, and Joint Commission required a documented plan for addressing security concerns. So in 2003, VHA established facility disruptive behavior committees, and they were tasked with using evidence-based, data-driven practices for preventing, identifying, assessing, managing, reducing, and tracking patient-generated disruptive behavior. So they're composed of senior clinicians. Dr. Hendrick is here and was been a significant part of that from the beginning. We also have other clinicians with psychiatric behavioral primary care expertise, emergency room, mental health nursing, community living center representatives, police, patient advocates, residential treatment representatives, patient safety officer, and union involvement. In 2010, the Veterans Health Administration directed that emergency department and urgent care clinic staff receive training in prevention and management of disruptive behavior and regular refresher training and routine drills. So those areas are supposed to have our training every 2 years. In 2003, we implemented computerized advisories known as patient record flags, and those are designed to improve safety in delivering health care. It was an approach developed by David Drummond at the Portland VA and was credited with reducing violent attacks by 92%. So the idea was to identify, in the same way the emergency rooms often talk about frequent flyers, people that are, there's typically a small population of individuals that produce a high number of disruptive incidents. And the idea was by alerting staff to those particular individuals, they can use a data-driven plan that's agreed upon by people with expertise in the area about how to deal with or be alert to those situations. And then we've got the prevention and management of disruptive behavior. That's been ongoing since the 70s in the VA. Right now it involves 4 levels of training. They include online and face-to-face instruction, role play, and skill practice. Level 1 is a web-based course. It's for all employees. It involves sexual assault and violence prevention awareness training. It's the only level of training that's required for employees determined to be at minimal risk for workplace violence based on the facility's workplace behavioral risk assessment. And so that's for positions that show very few or no verbal, physical, sexual, or criminal disruptive behaviors. It provides a general overview of workplace violence in healthcare settings, introduces information relevant to identifying signs of escalation that may indicate increased risk for violence, introduces concepts of sexual assault prevention, reviews basic intervention strategies, and provides information on working with VA police and reporting incidents. It's used as part of our new employee orientation, and it's also required for all new employees within the first 90 days of hire. So the track level 2 is for low, moderate, and high risk. It's now online too because of concerns of the amount of time it was taken for the training. This reviews types of violence, risk factors, stress levels, and interventions and reporting. And that's for low level. As is the level 2B, as for low, moderate, and high risk employees. That involves instruction and role play, and that's where we've gotten rid of all the online training. It's not really educational anymore. It's really focusing on doing role play settings of customer service, verbal de-escalation, and limit setting techniques. Level 3 is, level 2 is for areas where verbal disruptive incidents have been reported, but very few or no physical disruptive incidents. That's really for anybody that's got face-to-face encounters with individuals. The level 3 is for moderate and high risk. Instruction involves instruction and skill practice. It's personal safety skills to avoid, escape, and block holds, kicks, and strikes, and talk about personal safety and personal space. And that's for where both verbal and physical disruptive incidents have been reported, but no incidents that have required physical containment. And level 4 is for high risk. That involves instruction and skill practice. It's a called therapeutic containment. It's a team approach to safe containment of physically aggressive patients, and that's required for areas of high risk, and that's where the WBRA, the Workplace Behavioral Risk Assessment, shows that physical disruptive incidents have occurred that have included incidents that required staff to physically contain patients. A disruptive behavior reporting system is a online or web-based reporting system. It's a secure system. It asks you to report any type of disruptive behavior. It feeds into, and the main purpose is to serve as a tool to promote a safe environment, so we encourage reporting. The good thing about that is it feeds into, it's very simple to fill out. You click on this icon. It's on our homepage, and like 5 components. It takes about 5 to 10 minutes to complete. And the great thing about that is it feeds now our workplace behavioral risk assessment. So the report will automatically help to populate the behavioral risk assessment, and that's how we determine which level of training you're required to have. So last slide, and then we'll have time for questions. Talked about the Disruptive Behavior Committee. Oftentimes there are some limits on what we can do. We try to be flexible. We try to use the lowest possible intervention to try to resolve a situation where someone's been disruptive. So typically we require supervisor intervention to try to improve customer service. Also allows for due process, get their side of the story. And so that's very key. We ask that supervisors do that prior to supporting reports. And then typically people might be having a bad day. They get upset. They've had a long wait. We might just log and monitor. We can then see if there's a pattern. As I said, typically most of your disruptive patients are repeat offenders. So if we just log and monitor, then most of them are not going to be repeat offenders typically. If it's more severe, we can send a warning letter, either from a member of our committee or our police chief who's a member of the committee, and that tends to get attention. We can also bring them in for what we call an administrative clinic. We hold that clinic in the police chief's office, so they meet with, it's an administrative, not a treatment meeting, just to reinforce our goals for safety and try to enlist their cooperation. Also allows for due process. If it's considered severe enough, and we try to limit patient record flags because we want people to pay attention to them. If it's severe enough, the committee can decide to implement a record flag that warns of increased or elevated risk. It may have a specific plan that also might include encouraging staff support, staff standing by, police check-in, police standing by or walking through the area, or in severe cases, police escort. So we've got about 40 or 50 of those patient record flags that are active at any one time, so it's a pretty small number. We can also do referral to outpatient services. Obviously, that's something we don't like to do because oftentimes we have as much or more security services available. But if it's a personality conflict, oftentimes it can just solve problems just by getting someone through the VHA through the choice program, get them a provider that they don't have a conflict with. We can also recommend employee training. What we can't do is we can't ban patients from care. By law, unlike private sector, we have to provide a full range of services. And what we can do if a person is dangerous, we can do what's called an order of behavioral restriction. And by law, we're entitled to restrict the time, manner, or place of care provided to increase safety. So a typical example of that might be someone acted out in our one of our community-based outpatient clinics where they don't have police or security available. Then we can require that they come to our main facility where we do have police and they can check in. So those are the types of things we do, and that's my presentation. And if you all have any questions or experiences you'd like to share. Oh.
How many people do you have, if any, on the order of behavioral restriction?
Very, 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 very few. Just a couple. What's more typical is a police check-in. Police tend to prefer that because the police escort, they've recently hired some more police, but they want to be flexible and have police being able to respond to emergency services. So we have very few. So it's single digits.
I had the privilege of working with Dr. Cook for 12 years on this.
Okay. Bringing flashbacks.
Yeah, yeah. There's a little PTSD associated with some of it. I note that you understate your very important role, particularly as you are far and away, most commonly the author of the patient flags. Mm-hmm. And that in and of itself is a skill set that's not easy to attain. I think that one of the things that I'm getting increasingly worried about is, we have the one homogeneous record. And the one concern that I'm seeing is with these new designer drugs, we are seeing these incidents more and more frequently. People are coming in intoxicated in things that we can't identify. Maybe 2 weeks later, we might have a chance at making the identification. And for instance, I can think of a case recently, not only this guy get into it with 4 officers and managed to hold them at bay, but in fact required several days of general anesthesia before we could get any kind of behavioral control whatsoever. He was far beyond the use of antipsychotics. And we've had several of these incidents in the past several months. I'm just very concerned about the degree of increase that some of these new designer drugs are pressing into this system. Mm-hmm. And I know that you've had some experiences with these folks after the fact. It's interesting that after the fact, they themselves are often more scared of the situation than you can imagine because they sort of look back and see some of what happened. They often don't remember the worst of it.
Mm-hmm. Yeah, a few years ago, and you're talking particularly bath salts is probably the main culprit there. A few years ago, we had the shops before we had the laws enacted, where those shops were popping up everywhere, and I think that they were having those problems outside in the community as well as we were having in the VA. It does seem to be that there's a resurgence of substances that are difficult to detect and that are available online. So, yeah. Yes.
Mine's not really a question. I just wanted to add to a little bit of what you're saying. I work in retail, and we often have online training ever so many months or sometimes every month that works with workplace violence, either dealing with customer service or dealing with other disgruntled employees. And some of the things you were talking about with de-escalating a situation are real things we use in that environment as well. So it's interesting that it's just in the medical field, but also in retail, trying to de-escalate using a softer tone, understand what they've experienced. Maybe they have lost an amount of money or gotten a bad return. So really just listening with ear and an open mind and understanding what that customer is through usually helps you deal and de-escalate more often.
I appreciate you saying that, because I think that's the best defense for us against being victims of workplace violence is really excellent customer service. And too often, I think we think that I think that people that aren't practicing those skills can get themselves into trouble and project the blame on the situation, which it rightly belongs onto the person who's committing the violence, but they can help reduce their risk by how they handle that situation, and it is a skill set. So, yeah, it's a good point. As well as, since you bring that up, environmental layout. I'm sure that's probably an issue with our retail trade. I know that we're in the business or going to be moving offices, I saw recently, and so I'm hoping that people are going to be considering multiple exits and different safety designs that are important. And going back to also Dr. Hendrick's question, and I'm also reminded of, because the Obama's recent increase in the cap on Suboxone from 100 to 200 providers, personal contact with the community, law enforcement, a lot of diverted Suboxone certainly cause problems. I've seen problems with other substances and their personality changes. I have some concerns about that. And so hopefully they'll be closely supervised because I know pharmacists that have also been expressed concern that people seeking Suboxone have have been at high risk, we'll put it that way. So, any other comments or questions? All right, thank you.